A very warm good morning again to all of you. And this time we are going to speak about precision in diabetes management. Now, this is a boy, a 13-year-old boy who was diagnosed, you can see, as new onset type 1 diabetes. But then the caveat is type 2 diabetes having onset in adults and type 1 diabetes in children is not often true. It could be the other way around also. This is the boy. So like in this case, in any patient in whom you would see diabetes, we should be asking ourselves three questions. One, is it diabetes? Two, if so, which type it could be? And three, what could be the precise treatment for this person? So that's what brings us to the precision in diabetes care. So the first question is it diabetes? A fasting plasma glucose of more than 126, a postprandial glucose of more than 200 on more than one occasion, or a HbA1c of more than 6.5% would be diabetes. If the person has symptoms, even one plasma glucose value of more than 200 milligrams would qualify for diabetes. If the plasma glucose is more than 100, less than 125, fasting, more than 140, less than 199 after glucose load, and an A1C between 5.7 to 6.4, it is pre-diabetes. So pre-diabetes is otherwise called intermediate hyperglycemia. And you can note here, the only difference between the WHO and ADA is that WHO says that a fasting value up to 110 is normal. That means 110 to 125 is pre-diabetes. Now, this is a whole new concept which has come up, which we showed you in the Prelude CME, the 1 hour post-glucose 1 hour post-glucose value. So now the scientific parlors are asking this question, especially the International Diabetes Federation, why wait for 2 hours? Why not check at 1 hour? And it's been seen that a 1 hour value of more than 155 and signifies pre-diabetes, and a 1 hour value of more than 210 after glucose load signifies diabetes. So this probably is going to soon replace, and probably you all will be the first people in India and in the state to know that yes, this is coming. Because you need not wait for 2 hours, the targets would be different, and 1 hour is fairly good according to WHO and IDF. Now we come to the most important question on what type of diabetes it is. That 90 diabetes are type 2. So we know type 2. But just see what that rest of 10% would add to. We have 101 million people with diabetes. That means 1 million people are having other forms of diabetes. So at least 10 lakhs of it. So it's a huge number. And even in our practice, often 10% of patients are not having the typical type 2 diabetes. So it's very important to know, like, what is the correct diagnosis of the patient, because only then we'll be able to offer the best treatment. So we have type 1, we have type 2, we have various specific forms, and GDM. Often we read only about type 2 and we skip the rest. But today, I'm going to emphasize mostly on the other types. You can see here, if the person is old, type 2 is more, but still other types are there. But if the person is less than 20, you again see there, it's not other forms. 50% or more than 50% is still type 2. So for a patient aged less than 20 years, still you have a high chance of type 2, especially in the emerging world. Now, what is type 1 diabetes? There is insulin deficiency. There is affection of the pancreatic beta cells. Typically, the person is young, often with a low BMI. The person presents usually with weight loss. and sometimes with ketoacidosis. And the plasma glucose, when you check, is very high, 360 or more. And there could be other features like ketosis alone without acidosis, osmotic symptoms, family history, history of autoimmune diseases. Various autoimmune diseases have been told there. So if a person has autoimmune disease along with all these features, then probably it is type 1. Now, then again, we have gone little beyond diagnosing simple type 1. Type 1 again could be different stages like type 2. You have the stage 1 where you have the antibodies which are present, but the person's blood glucose is normal. Stage 2, antibodies are present, glucose is pre-diabetes stage. Stage 3, glucose is high, but mind you, in this stage, the antibodies may be absent. So these are and why should we know about different stages? There is a new molecule which has come up, which is called teplizumab, which you can use in early stage 1 or stage 2, which can delay the onset of stage 3. That means type 1, to an extent, is preventable. Now, even in type 1, there are various forms. It could be type 1, endotype 1, or endotype 2. And what is the difference? You check antibodies to see whether it is type 1. It is told that in endotype 1, insulin antibodies are seen, whereas in endotype 2, it is GAD antibodies which are seen. And the response to immunomodulators are there only in endotype 1 and not in endotype 2. So it's of course, it's little extremely precise, but it's important to know that at least it is type 1 and, if possible, the subtype. Now you can see here, there is an entity called LADA, which is latent autoimmune diabetes of adults. That is a form of type 1 which occurs in adulthood because the progression is very slow. And a rapid onset usually occurs in childhood. One telltale feature of type 1 diabetes is that the C-peptide levels will be very low. So whenever in doubt, check C-peptide. So practically what we do, if the C-peptide is low, that means the pancreas is not secreting enough insulin. And if the pancreas is not secreting enough insulin, the treatment obviously is insulin. So this is something which we should keep in mind. This is the age, autoimmunity, body habitus, background control comorbidities, which I have already enumerated, like how we go about diagnosing. Now, see that slide. 5 to 10% of people with type 1 diabetes do not have antibodies. So when you check for antibodies, and if antibodies are negative, still it could be type 1 diabetes. Now let's come to the giant in the room, type 2 diabetes. We all know type 2 diabetes. But then we should know when not to suspect type 2 diabetes also. So in a classical type 2 diabetic patient, the BMI would be more. Weight loss may not be present because often it is found incidentally. When you check in a patient with weight loss, if a patient has severe sudden weight loss, always keep the possibility of something other than type 2. It could be type 2, advanced stage, but please consider other forms of diabetes also. Ketoacidosis is absent. The marked hyperglycemia is less marked. It will not be 350 or 450. Usually it is something like 200, 225 or whatever on diagnosis. Family history is very strong. Symptoms are mild. And features of other metabolic syndrome would be there. If the person has fatty liver, which now is called metabolic dysfunction associated liver disease, or hypertension, dyslipidemia, then the chance for type 2 diabetes is more. It's the commonest type, but again, mind you, commonness is not 100%, it is 90 to 95%. So as I already told you, it could be associated with atherosclerosis, obesity, and metabolic associated. Earlier, we used to call NASH and MASH. Now those terminologies have gone. It is MAFLD and MASLD. Now, there could be non-classical forms of type 2 diabetes. So all type 2 diabetes is not the same. In type 2 diabetes, there is a particular variety called ketosis-prone type 2 diabetes. What is that? Now, this person, earlier we used to call by different names, Flatbush, type 1, African, type 1.5, type 3, and so on. But right now, it is KPD, ketosis prone diabetes. So it is not type 1, it is type 2 diabetes. And how will you know that? The insulin antibodies will not be present. So the person has ketosis, but the person will not have insulin antibodies, right? So we have seen many patients who presents with ketosis, they give insulin, and then you know what happens? Once the acute episode is over, there is an insulin-free remission for years together. The patient will not require insulin at all. So it doesn't mean a patient whom you diagnose with ketosis, insulin deficiency, you started on insulin, it may not be type 1. It could be ketosis prone type 2. And in that case, the insulin requirement will vanish. And for years together, the patient will be free of insulin. At that stage, the sugar may be either normal, or if it is high, you can very well manage with oral drugs. And remission may happen after years, or it may not happen at all. So there is an overlap between type 1 and type 2. And how you distinguish? 1, antibodies are absent. 2, ketosis may be present. 3, there's a long period of remission without drug requirement and definitely without requirement of insulin. Now we come to another type of non-classical type 2 diabetes, which is lean diabetes. So most often this question is always asked, especially in my YouTube lectures and all. I keep propagating about reducing body fat, and many people ask, someone is lean yet they have diabetes. And we have seen a lot of patients with lean diabetes, and it is not uncommon. You can see here the data from various countries, and look at India, 5.4% in men who are underweight, and in normal weight, up to almost 40% of patients with type 2 diabetes could be normal weight. And this is a study from the INDIAB, where you can see that 6.2% of patients actually had low weight, less than 18.5 BMI. So when a person has lean diabetes, it's not the same as type 2 diabetes. In fact, it is told that the chance for complications are more in patients with lean diabetes. And what is the difference? You see there, the C-peptide values are normal. So that is, in a lean patient, you look at C-peptide. If it is low, possibility of type, or very low, the possibility of type 1 is there. But if it is not too low, then it could be lean diabetes. In classical type 2, the C-peptide values are actually high. You can see that there. Now, compared to type 2 diabetes, the insulin secretion in lean diabetes, you can see that the blue line is lower than the black line. That means the insulin secretion is low, but look at the second graph, the insulin sensitivity is higher than type 2 diabetes. So that means insulin secretion is low, but insulin resistance is also low, which means that not very high doses may be required. But you can see there, the requirement of insulin is much higher than in type 2 diabetes, though not as much compared to type 1. So when the BMI is going up, you can see the insulin requirement is actually not going up. You see the last line. The insulin requirement is maximum in the first line, which is the lean diabetes. So that is why it is important to identify that. So it's a specific form of type 2 diabetes. Characterized by male preponderance, lower age at onset, blood pressure, triglyceride, but higher glucose levels, A1C, and microvascular disease. And therapy for lean type 2 diabetes may be different from that of obese diabetes. So I'll come to that a little later. Now we have this form of diabetes called pancreatic diabetes. We have all had patients who come and say that, doctor, I have had a pancreatitis before. It could be an acute pancreatitis. It could be a chronic pancreatitis. It could be an acute on chronic pancreatitis. It could be a calcific pancreatitis. So any form of pancreatitis, you can see here, all these etiology can produce an exocrine and endocrine deficiency. It's called type 3C diabetes, but classically pancreatic diabetes. Two things you have to remember. One, you can treat with any agent other than incretin-based therapy. So it's not advisable to give incretin-based therapy in patients with pancreatic diabetes. 2, these patients may require insulin at an earlier stage than type 2 diabetes. Now we come to a very interesting form of diabetes called monogenic diabetes. Monogenic diabetes is not type 1. Monogenic diabetes is not type 2. Type 2 is polygenic diabetes. Now, this usually occurs in early adulthood and children. So when a child comes, the person is not having type 2 diabetes, type 1 diabetes. And when the child reports to you or a young adult reports to you, when you seek the family history, if only one parent has diabetes, it is probably, there is a possibility of monogenic diabetes. One parent with diabetes. And when you look at the family history, you can see that in successive generations, you see here, this female is affected. In her next progeny, the chance is 50-50. And in the next progeny, you can see, the next progeny, you can see. So usually, if you draw a family tree, like with their parents siblings, with their grandparents, you can see that it affects all generations, but not everyone in all generations. So this picture, if you can, put it into your paper, it indicates that it is monogenic diabetes. What is monogenic diabetes? There is defect in one gene on a chromosome. That single gene. So 10 years or 20 years from now, yesterday we had a meeting with the Chief Minister, John Manikar sir was also there. In fact, I was mentioning in my address that we should have facilities in the state for genetic determination, especially in diabetes variation, because only with that we can address this issue, right? Now, absence of typical features of type 1 or type 2, and features of other monogenic causes can be there, like renal cyst, partial lipodystrophy, maternally inherited deficiency, inherited deafness, and so on. So it's an autosomal dominant inheritance. Typically, age is less than 25 years, and at least 3 generations are affected. I showed you that. And genetic testing is required. There are at least 14 types of maturity onset of diabetes in young or MODY. That means 14 different genes could be affected. The commonest ones are 2, 3, and 1, and you can see which genes are affected. These are so all MODY is not the same. Based on which type of MODY, the treatment would differ. You can see the last line, like some people would require sulfonylureas, some people would require insulin, and some varieties do not require any treatment at all. In fact, the commonest variety of MODY 2, one of the commonest varieties, no treatment is required. There is only mild hyperglycemia. Sulfonylurea is the first line of treatment for all forms of MODY, but second line, incretins can be used for MODY 3 and MODY 1, but not for MODY 5, where insulin is the treatment of choice. And how will you know which MODY? You can know only if you have a genetic diagnosis. Other you can only say. So that is where we are coming to precision in diabetes care. Right now, even diagnosing MODY, MODY is a big challenge. To diagnose further, we do have facilities, but we need precise diagnosis. Now, how do you distinguish type 2 diabetes and MODY? I told you, onset of age, MODY is at a much younger age. Inheritance is autosomal dominant. The other one, multiple family members will be affected. Both parents may be affected. Here, only one parent is affected. And BMI is usually normal here, whereas it is high there. And autoantibodies are negative in type 1 as well as, type 2 as well as monogenic diabetes. There is a specific variety of diabetes called neonatal diabetes. If an infant is diagnosed with diabetes before 6 months of age, it is not type 1, it is neonatal diabetes. Because type 1 diabetes occurs only after 6 months of age. And neonatal diabetes is again a single gene mutation. And in neonatal diabetes, the drug of choice is not insulin, it is sulfonylurea. So that is why we need to know about this entity as well. Now, broadly speaking, when a patient comes to you, how will you diagnose? One, the family history. It's very, very important. Family history is very important to tell us whether it is type 1. In type 1 diabetes, most of the type 1 diabetic patients will not have a family history of diabetes. But if there is a family history of type 1, the chance for type 1 is more in the sibling. You get it, no? So you have a detailed history, have a detailed clinical examination, look for other metabolic diseases, fatty liver, polycystic ovary, acanthosis nigricans. So, and finally, we come to the autoantibody test, and antibodies are positive, it is type 1. Antibodies are negative, it is anything other than type 1. But I told you that antibodies could be negative in type 1 also. And finally, you also go for C-peptide, and C-peptide can tell you, at least not the diagnosis, but it can tell you whether insulin requirement is there or not. So having said so far, now I'm left with around 8 to 9 minutes to discuss on how we go about treating diabetes. Now we know that all diabetes cannot be treated the same way. So lifestyle behavior, of course, for all types of diabetes, this is something which is very common, which is common to all of them. And diet, again, we are going to discuss about that. Physical activity we'll discuss. Sleep also, we have a special session on sleep. Ideally 6 to 9 hours, and you can read the rest from the slide. For prevention, lifestyle measures are the key. There are a lot of pharmacological agents, but none of them are officially approved for prevention. Now, this is something which we need to know. These are simple lifestyle measures, but go a long way. Like walk at least, break up sitting. Don't sit for more than 30 minutes. At least 10,000 steps a day. Sweat as much as you can. Strength training at least 3 days a week. Adequate sleep, I told you 6 to 9 hours. 7 hours is ideal. Good sleep quality and consistent timing of your daily routine. So that has an effect on all metabolic parameters. And what are our glycemic targets? We are planning for a HbA1c of less than 7%, a pre-prandial capillary glucose of 80 to 130, a peak postprandial capillary glucose of less than 180. And by peak postprandial, we mean no sugar value between 1 and 2 hours post-meal should be more than 180 milligrams per deciliter. Now, let me invite your attention to the figure in brown, 70 to 144. What is that? International Diabetes Federation is saying that your fasting value should be 70 to 144, and your after-food value also should be 70 to 144. Does that mean you should not eat? So that means your stomach shouldn't know how much you are eating, should be very, very, very little. And even if you do not eat, IDF is coming up with its latest advance, which is actually fasting guidelines. So we'll talk about that a little later. So if we consider that 180 is okay or 200 is okay, sorry, 144 is ideal, but definitely less than 160. You can see here, this is the latest IDF guideline. There is also a technique called continuous glucose monitoring, where you check 24-hour glucose for 14 days. And most of the time, it should be within acceptable range of 70 to 180. You can see here more than 70% of values should be within acceptable range. Not more than 4% of values, less than 70, and less than 54, only less than 1% value. IDF also says the same thing. But if the person has short duration of diabetes, long life expectancy, no comorbidities, and no chance for hypoglycemia, you go for a much tighter control. Aim for an A1C close to 6. But if the person is morbid, multiple morbidities, old age, limited life expectancy, you can gravitate towards 8% HbA1c. Now let's come to the treatment. For type 1 diabetes, there is only one drug, the classical drug. Of course, various other drugs are being studied. We had a presentation on, in fact, we are streaming a presentation on GLP-1 analogs and SGLT2 inhibitors for type 1. But classically, type 1 is treated with insulin. And for insulin, there are two ways in which you have to give insulin. One is the basal insulin, which you will give to cover the pre-meal values, and the postprandial insulin, which you will give to cover the after-meal values. And roughly the dose is around 0.5 to 1 unit per kilogram per day, and 30 to 50% of which is given as basal insulin. It can be given in various patterns, either through an insulin pump or multiple injections, and multiple injections also, multiple daily insulins and multiple, multiple basal and multiple postprandial based on patient's sugar profile. Now we come to the vast majority of patients whom we are dealing with, that is type 2 diabetes. There is a lot of changes which has happened with the management of type 2 diabetes. So when you call, and this is the latest ADA guidelines from 2025, the first thing, no doubt, is healthy lifestyle measures. So please don't forget, with all the armamentarium of drugs we have, there is still healthy lifestyle measures is the first choice. But if that alone is not sufficient, then we have to ask this question. Is the patient having cardiovascular or kidney disease, or the patient has a high chance for such disease? If the answer is yes, you go for the maroon column. If the answer is no, then you set your goal. Is it A1C reduction alone or A1C reduction and weight management? So if the person has a cardiovascular disease, like means he has a coronary artery disease, he had a stroke, he has multiple strong risk factors for coronary artery disease, then please stick to the first option. And in the first option, if the patient already has a disease, cardiovascular disease, or a heart failure, then GLP-1 analogs or SGLT2 inhibitors are the first line drugs which are to be used. GLP-1 analogs is liraglutide, and all the other analogs which we are semaglutide, all the other analogs. SGLT2 inhibitors, fortunately, now they are very cheap. Empagliflozin, dapagliflozin, and so on. So GLP-1 analogs are very costly, so let's consider SGLT2 inhibitors. Now, if the person is not getting controlled, add one more agent, still not getting controlled, then finally you go for other combination therapy. And the same is true with heart failure. You start with SGLT2 inhibitors. Chronic kidney disease, again, drug of choice, GLP-1 or SGLT2, and then you combine them. But if the person does not have any of the cardiovascular diseases or high risk, then you target what is more important. If weight management is more important, then either you can start with semaglutide tirzepatide, which will be discussed in the next lecture, high potency for weight loss, dulaglutide, liraglutide, GLP-1 analogs, which is high potential for weight loss, then intermediate, then neutral metformin DPP-4 inhibitors. So all these drugs are considered in patients in whom weight gain could be a problem and the person does not have cardiovascular disease. And if the weight gain is again not an issue in a lean diabetes or so on, you can consider any of these and see where sulfonylurea is coming. So almost all our patients are right now getting sulfonylurea, but you see here that the current guidelines, this is the only mention of sulfonylurea. So we have to think beyond the routine treatment. Because sulfonylurea, other than reducing blood glucose, does not give any other benefit. Whereas the newer agents give multiple benefits other than reducing blood sugar also. And this is the IDF guideline from 2025, where sulfonylurea doesn't come at all. In this guideline, there is no mention about sulfonylurea. So I'm not saying that we should all stop sulfonylureas, but then reserve it for that rare patient who would actually require that. But otherwise, most of the other agents are preferred. And the IDF guideline says that metformin is the first line treatment. And I also personally do agree that it is definitely one of the best drugs, and all the others can be considered later. So these are doses of various drugs, which most of you are aware about. Otherwise, I'll share the slides. You can read it from there. These are all the other drugs. And this is how we initiate injections, either as GLP or as insulins. And this is a fairly simple slide from the IDF, which says that start with basal insulin. The patient is not getting controlled. Add prandial insulin. Monitor blood sugar during different times. And based on the requirement, titrate the insulin. Insulin, all insulins are not the same. There are various forms of insulins. This is the ultra short-acting insulin, which is insulin Lispard, glulisine, Lispro. This is our usual regular insulin, which peaks little later. NPH peaks at around 12 hours. and last for around, peaks at around 6 hours and last for around 12 hours, 12 to 20 hours. And these are the long-acting insulin like Glargine, Detemir, and right now we also have Degludec, which is again a long-acting insulin. So the long-acting insulins are given to control the pre-meal values, and the prandial insulin is given to control the postprandial value. Now, if you ask me, is there a big difference between them? Actually, it is not. Still, the conventional NPH and regular insulin is fair enough, good enough, as long as you can achieve control without hypoglycemia. And now, lean diabetes, again, you will consider insulin much earlier. Now I am coming to the final part of my talk, which is the actual precision in diabetes management. So right now, I was talking about the precision which we all need to acquire in our daily practice. But in the next decade or so, we are going to go much beyond that. All these definitions are going to disappear. They are going to be redefined. And what is that? There was a path-breaking lecture which we had telecast during this IDF on precision diabetology. Now you see here, it's little tricky, but I'll invite your attention for 3 or 4 more minutes and then I'll stop. You can see here, type 1 diabetes, yes, insulin secretion is low, but not in all type 1. In some, insulin secretion could be high. Not high, but not very low. Type 2, insulin secretion is high, but in some type 2, it could be very low. So just based on insulin secretion, we cannot say whether that this is type 1 or this is type 2. And look at insulin sensitivity. Classically, insulin sensitivity is high in type 1 because there is no resistance. There is only deficiency. And type 2, it is resistance. But look here, some type 2, the sensitivity is fairly good. So that means our present classification and 1 and 2 may not be that accurate. And a group of scientists from Germany, based on these 6 parameters, GAD antibodies, A1C, BMI, age, HOMA2 and HOMA2 IR indices, have developed a new classification, which you can see here. That is severe autoimmune diabetes, severe insulin deficiency diabetes, severe insulin resistant diabetes, mild obesity related diabetes, and mild age related diabetes. Because it is not type 1 or type 2, it could be one of these variants, and based on that, your treatment options and even your complication chances could be very different. You can see here that the severe insulin resistance diabetes, the green one, has more complications everywhere. You can, other than peripheral neuropathy, where it is the insulin deficiency diabetes. You can see that. So whether it is 1 or 2, if the person has, whether the person has more resistance or more deficiency, or is it only a mild diabetes with age. And then in various countries, the proportions could be different. You can see here. So it is not that there could be a global guideline. We'll have to tailor the guidelines to our requirement based on these factors. And when you plot, and it is not even enough that you look at those 6 things, you will also have to look for newer emerging things in the genetic and somatic background. And then you plot the insulin sensitivity, insulin secretion, and various other factors, and you plot this graph. But often you see that there is considerable overlap. So ultimately, the design looks something like this. I know it's a little complicated, but all it means is taking various factors into consideration, you try to place where the patient is. He will not fix into one column of type 1 or one column of type 2. He may fix somewhere here, he may fix somewhere here. And based on that, the treatment options could vary. And that's called the palette model. Now, I'll just show you one more slide and I'll stop. Now, this is a study which happened based on these characteristics, 9 routine clinical features. They tried to assess the response of these 5 drugs. And based on these, they could predict the response. And the response, again, in various phenotypes were different. You can see here, GLP-1 was very effective in ladies, whereas SGL2 was more effective in males. So even within our type 2 treatment armamentarium, there could be various differences. And you can see here, based on various other criteria like BMI, current age, and so on. Then this is the 5-drug class model, which is published just recently in 2025, a new treatment methodology which is emerging. And they have given a calculator to arrive at that. This is on how you can know which club. This is just an investigation tool, so we will not use it in our clinical practice, but this is what they have revealed on how they categorized on which drug would be good for this patient based on those 9 characters. Understand? This is the German QR, and this is from the MDF Diabetes Research Foundation, and they are also trying to subclassify the patients based on those criteria. Now let me come to my last slide. The story of that little boy is complete with this slide. You can see his father there sitting along with him. So is it diabetes? Yes. Which type? Maybe type 2, or maybe another form of genetic diabetes with high insulin resistance. And what could be the treatment? So in every patient, it may appear very simple, straightforward, but it may not be, and we have to go much beyond our routine care to arrive at what we call the precision in diabetes care. So to summarize, a 1-hour postprandial glucose is important. Define the type of diabetes, look for specific features, treatment should be tailor-made. There's an emerging role of GLP-1 analogs, SGLT2 inhibitors, especially in patients with coronary artery disease and renal failure or chronic kidney disease. Insulin has to be titrated, and precision is the future direction. I thank all of you for your patient listening.